Okay, good afternoon, everyone. This is Debbie Nadzam Melnyk from VCSQI, and this is the second meeting of the Opioid Management Workgroup. As people sign on, hopefully they will still be noting that they're present in the chat box. So all primary contacts of our practices have been invited now. You all should have received calendar invitations by now. I update as new practices come on board. I see Ivan has joined the call as well. At the top of the agenda here is just a reminder of the objectives of this work group. I'm not going to read through them, but really it's a learning opportunity for everyone to hear from each other, to review best practices, and address the opioid prescribing practices within their practice. Are there any agenda items to add besides those that are listed here already? You can type it in or say it. I know some of you are just on the phone. Okay, well, hearing none, we thought we'd give you a little bit of an update from last week's annual CMS conference. Eddie, Ivan, and I were all in attendance and attended some of the same sessions, but also split up to attend different things. So I'm just going to give a little bit of update from what I heard first relative to the charge of improving opioid prescribing across the country. In general, I'll say there was still quite a bit of attention. This is that annual quality conference that quality improvement networks and other organizations with contracts with CMS are requested to attend. And so all of the practice transformation networks and support and alignment networks were there, and gosh, there were at least 1,000 people in attendance, I think. So one of the master classes that was offered for TCPI contractors was focused on opioid prescribing. And so I attended that one, and there were 3 speakers, one from CDC, one from SAMHSA, which is the substance and alcohol section, substance abuse section under HHS. And then a third speaker was from the University of New Mexico. So Dr. Losby from CDC reviewed the statistics indicating that we really do have an epidemic in the country of opioid misuse. Gave some of the more recent numbers. 2016, there were more than 63,600 drug overdose deaths in the country. Talked about how 11% of Americans report chronic pain, and as we know, the opioids commonly prescribed to address that are Vicodin, OxyContin, oxycodone, morphine. She highlighted the CDC guidelines, which we'll talk about a little more in a minute. Just giving high-level update information about them, but also encouraging everyone to go to the website. There's a checklist, a pocket guide, a mobile app to help providers calculate dosage, as well as information about motivational interviewing, which is a technique to understand where people are in their lives with willingness to change. There are also consumer and patient education materials on CDC's website with fact sheets, posters, videos, and testimonials, things you can use even in your offices if desired. Dr. Campbell from SAMHSA is a clinical pharmacologist and talked about strategies that HHS and SAMHSA have underway on this topic, increasing public health surveillance, advancing the practice of pain management, increasing access to treatment and recovery services, targeting availability and distribution of overdose reversal agents, and supporting cutting-edge research. There are grants available through SAMHSA to help address medication-assisted treatment. So he did talk about the Drug Addiction Treatment Act and the use of I can never quite say this right, buprenorphine. Buprenorphine, which is a medication treatment for opioid addiction. It is like methadone, although not as strong, so it can be managed more easily on an outpatient basis. The Comprehensive Addiction and Recovering Act of 2016 expanded who can prescribe it. So now, besides physicians, nurse practitioners, PAs, and advanced practice nurses can also prescribe this. So that was a big addition in terms of the availability to patients, knowing that these other prescribers are now allowed to prescribe buprenorphine. The speaker, Dr. Bartlett from University of New Mexico, spoke primarily about medication-assisted treatment and really called it medication as the cornerstone to treatment. I'm hoping that the slides from these presentations from last week are available soon on CMS's website. I don't know, Eddie or Ivan, if you've looked for them or found them yet. But as soon as we do, we'll be making them available to everyone. Ivan, did you want to add anything in terms of what you heard last week at the conference related to opioid management?
I heard a lot of the same concerns and perspectives that Debbie shared. One of the things that continues to strike me is as we talk about these things as individuals, as we talk about them as groups and practices, and as we're talking about them in hospital settings, those three different groups are still not coming together to formulate guidelines and just consistent communication practices and standards that are being shared and done in unison. There's so much that is being done in disparate corners, and there's just that overarching need to bridge and facilitate discussion and create, a more comprehensive approach and plans. So for me, it speaks to the value of work like this and the contribution of many lending itself to solutions.
Okay, thank you. Eddie, do you want to add anything?
No, nothing really to add from mine. I think you guys covered it well. Just that CMS has really, prioritized the opioid crisis as a nationwide epidemic, and they are devoting more resources to this on the national scale as well. So we are right here, I think, in the right place.
Yeah, the CMS administrator also spoke and emphasized this as well. So it came up in almost every session that we were in attendance at anyway, that it's a priority of the new administration. Well, not so new anymore, over a year old. And grateful that we are all working with our, enrolled practices to try and help everyone play a part in reducing the number of opioids out there. Okay, I'll type in a summary of what we said once I finalize these minutes. So I'm not going to do that now while we're all on screen together. Do any of you have any questions or comments or even contributions of things that you've been hearing in your own locales about this priority? Okay. Okay, so the next agenda item really is kind of the focus of today's work group, and that's specifically related to prescribing guidelines. So last time we just barely hit upon the fact that CDC has these. So what I wanted to do today is just spend a little bit more time on them. But I have to find what I opened up here. Here we go. So when you go to that link that's in the agenda and will remain in the minutes, this is the document that you will get to. And it is, it's probably 40 or 50 pages in length. So we're not obviously going to read it. I just wanted to highlight a few things and then look at the recommendations. So the guideline is really primarily focused and developed for primary care clinicians, as you can see here, who are prescribing opioids for chronic pain outside of active cancer treatment, palliative care, and end-of-life care. So all of you on the call so far are not primary care, but I think it's valuable to kind of look through this and consider the 12 recommendations and what's beneath them and how, in fact, it might apply to some of the ways you may be prescribing opioids for acute pain. So there's some background given and rationale. You know, it's not uncommon to hear, we're not the problem. The problem is, you know, all these drugs coming in illegally and the drugs on the street. And of course, that's part of it. But we know that overprescribing has been occurring as well, which just leads to more opioids out there available and more people potentially becoming addicted. So that's part of what this rationale addresses, as well as indicating that many primary care clinicians have said they're not comfortable with how they're prescribing them, and they know that they could use more guidance around this. So this continues to really just address the fact that, you know, what the audience is. And then there's quite a bit of discussion about the steps CDC went through to develop this guideline. You know, developing evidence-based guidelines is not a simple procedure. There's a lot of review, not only of literature, but experts who serve as the primary work group and expert panel reviews and input from the public when you're a government agency like CDC. So these next several sections address how the CDC went about convening, researching, getting feedback, you know, and landing on their final document. There were 5 clinical questions that they addressed in their review. Briefly, the effectiveness of long-term opioid therapy versus placebo, no opioid therapy, or non-opioid therapy for long-term use. The risks of opioids versus placebo or non-opioids on abuse, addiction, overdose, and other harms. The comparative effectiveness of opioid dosing strategies. The accuracy of instruments for predicting risk of opioid overdose, addiction, abuse, or misuse, and the effects of prescribing opioid therapy versus not prescribing opioid therapy for acute pain on a long-term use. So that kind of structured the review that the experts undertook, the review, the work group. And you'll see as you go to this document yourself, and we'll have the link on the website in addition to still in the minutes. There are other links within this document. I don't know if this is going to open up for me now, but there's much more detail provided in what they call their clinical evidence review. So these are all the methods they used, and then a summary of findings against those 5 clinical questions. For example, when it comes to harm, which was the second question, it says for KQ2, that's the key question number 2. The body of evidence is rated as type 3. There are 4 types of evidence commonly used for any type of project like this. Type 1 is really what you want to see. Type 1 evidence means that there were randomized clinical trials or overwhelming evidence from observational studies. And then as you go to type 4 evidence, there's clinical experience and observations, observational studies with important limitations, or randomized clinical trials with several major limitations. So you see, when it comes to harm, the body of evidence was really only at a type 3, which meant there were observational studies or randomized clinical trials, but they had notable limitations. So for the 5 general questions, there's a brief summary that follows here. It doesn't take too long to read, but that's not the point of, really kind of going over this now on this 1-hour call. More about the contextual evidence review and the primary areas of focus. Finally, you will get to the recommendations that came out of all of this, grouped into 3 areas: determining when to initiate or continue opioids for chronic pain. Second category or areas: opioid selection, dosage, duration, follow-up, and discontinuation. And the third is assessing the risk and addressing harms of opioid use. So there are 12 recommendations across these 3 areas. And for each recommendation, you can read more about the rationale for that recommendation, and that's what follows immediately here. So, for example, there are 3, each recommendation not only has the evidence type, so you can see here, this first recommendation, non-pharmacological therapy and non-opioid pharmacological therapy are preferred for chronic pain. So you can read more about that, but also it shows that the evidence type is only a 3 here, but the recommendation category is an A, which means you should consider this for all patients. 11 of these 12 are category A's. 1 is a B, which means you might have to do some individualization for the patient. So each of these recommendations has a full description of the rationale, what category and what evidence type exists. I skipped over the second one here. Second one, before starting opioid therapy for chronic pain, clinicians should establish treatment goals with all patients, including realistic goals for pain and function, and should consider how opioid therapy will be discontinued if benefits do not outweigh the risk. So the first 3 recommendations are all part of deciding whether to initiate or continue opioid therapy. There's a handy box later on that just lists them all as well. But this is where you get the detail behind each one. The second major category relates to opioid selection, dosage, duration, follow-up, and discontinuation. And this is where there are several recommendations. Actually, 4. 4 of the 12 recommendations fall into this category. In looking at these in more detail, you'll find that some of these points will relate to even how you prescribe opioids for acute pain. So I would encourage you, as you begin to really look at your practices, to consider some of these recommendations about what to prescribe, dosage, duration, and follow-up. You can see this very first one says, when starting opioid therapy for chronic pain, clinicians should prescribe immediate release opioids instead of extended release long-acting. Who knew? I mean, unless you really know all about the various configurations and types of opioids, this might not have been something a prescriber has thought a lot about. The next one in this category, when opioids are started, clinicians should prescribe the lowest effective dose. There's a table later on as well that shows the relationship of the various types of opiates to morphine. It shows the morphine milligram equivalents. And as you read through this set of guidelines, you'll see that there's good reason, according to the evidence that exists, to try and stay around 50 morphine milligram equivalents, not go over 90. The higher you go, the greater the chance that addiction can occur. And so these four recommendations within the second category provide more guidance on all of the dosing expectations. The third one in this category, long-term opioid use often begins with treatment of acute pain. When opioids are used for acute pain, clinicians should prescribe the lowest effective dose of immediate release opioids and should prescribe no greater quantity than needed for the expected duration of pain severe enough to require opioids. 3 days or less will often be sufficient. More than 7 days will rarely be needed. So this is the kind of detail you'll find. And then the last one in this category, clinicians should evaluate benefits and harms with patients within 1 to 4 weeks of starting opioid therapy for chronic pain or dose escalation. Then the last 5 relate to the final category, which is assessing risk and addressing harms of opioid use. So these recommendations address your assessment of the patient, the risk factors for opioid-related harms. This is where we get into potentially using those risk assessment tools we briefly hit upon on our last meeting. Scrolling down more, there's quite a bit of content with these recommendations. Recommendation 9, which is the second one in this third category, clinicians should review the patient's history of controlled substance prescriptions using state prescription drug monitoring program data to determine whether the patient is currently receiving opioid dosages or dangerous combinations that put the patient at high risk. That noise is me scrolling. The next one is when prescribing opioids for chronic pain, clinicians should use urine drug testing before starting opioid therapy and consider urine drug testing at least annually to assess for prescribed medications as well as other controlled prescription drugs that the patient might be taking unbeknownst to the prescriber. The 11th, clinicians should avoid prescribing opioid pain medication and benzodiazepines concurrently whenever possible. And finally, clinicians should offer or arrange evidence-based treatment for patients with opioid use disorder. And this is the buprenorphine or methadone in combination with behavioral therapies. So again, even though this particular set of guidelines is written with primary care and chronic pain management in mind, I think there's some good takeaways in these recommendations that any prescriber can learn from and potentially make some adjustments to their practice. I'm just going to scroll down a little further here. You'll see there are a ton of references, some of which are from other specialty areas. There's kind of reference in the beginning of this set of guidelines that other specialties have at least written position papers, if not offered some stronger guidance around how to prescribe for their patients. But continuing down here now, I just want you to see at the back, lots of references. Table 1 here is the grading of recommendations, assessment, development, and evaluation of the clinical evidence review ratings. So you can get a sense a little bit more about how these different actions were fell against evidence-based scoring. Table 2, which crosses pages here, is the morphine milligram equivalent doses for commonly prescribed opioids. So you see morphine is at a 1. That's the conversion factor. So here is where you see the commonly prescribed opioids and the conversion factor against morphine milligram equivalents. So hydromorphone, you're going to get to your 50 MME or 90 MME much faster than if you're prescribing codeine, for example. And then here's box 1 that lists the recommendations against the 3 categories. So it's, a shorter way of looking at it, but the detail behind each one is what we just scrolled through moments ago. And finally, box 2 interprets the categories and the evidence type for you, because in the longer description of each of these recommendations, in parentheses at the end of the recommendation was the category and the evidence. And it's actually this 10th recommendation. This is the only one of the 12 that's a category B instead of an A, which means individual decision-making needed. Different choices will be appropriate for different patients. Clinicians help patients arrive at a decision consistent with patient values and preferences. And so that recommendation is the one that says when prescribing opioids for chronic pain, clinicians should use urine drug testing. So I'm going to stop here. Here's all the steering committee members and such. It's pretty comprehensive. And again, on the CDC's website, you'll find a lot more information. One of the things that I pulled up to save is just this shorter fact sheet as well that I'll send out with the minutes. So here you see the 3 categories and the recommendations that fall under each of those 3 with some clinical reminders. This would be a much handier, document to have available for prescribers. So I'll send this out with the minutes as well. But again, this is for prescribing opioids for chronic pain, but some of them I think are relevant for anyone prescribing opioids. So let me pause and see if anyone wants to weigh in, ask questions. I'm not convinced we'll have all the answers, but we can help find them if others cannot. Nothing? Has anyone visited this site already? I see Janelle has added something about Tennessee. OIG top list to watch is opioid prescribers. We've developed a lot of rules to providers in the state. Tennessee was one of the top states of opioid abuse. So prescribers are being monitored more actively now. I think that's what Janelle is saying. Okay, following the chat box here. For those of you who aren't, I think everyone is on the computer, but Janelle says the medical record, she was told levels should be reported. And yes, there's a website to review the Tennessee rules. Maybe you can get that out to us, Janelle. Put it in the chat box and I can put it in the minutes as well.
Are there rules out for every state? Are there a list of similar rules?
I know most states have the prescription drug monitoring program in place. I don't know how many have gone the course of Tennessee. I wouldn't be surprised if there are more and more doing it, but that's a good question, Ivan. Maybe we can find out from the national group.
Yep, Florida. This is Steve Dickson. Florida has some on their state site. I looked at it once, and we'll have to go back and review that also.
Nice.
MDD. Did you mean the morphine milligram equivalents? MME. It's not supposed to go over 160. Janelle has typed into the chat box, right? All right. Well, again, I encourage you to go and look at these materials. You might even scroll through the references to find those that might be more relevant to some of the work that your prescribers are doing. I'm going to jump, before I turn it over and ask Steve to talk about what they're doing, I'm just going to jump to one of the updates because I probably should have had it up front. Eddie and Ivan and I and Dr. Rich had a chance to meet with staff from the Society of Thoracic Surgeons when we were at the annual meeting in Fort Lauderdale a few weeks ago. And that has led to an initial agreement to work together to create probably a position paper for thoracic and cardiac surgeons on prescribing for post-op procedures. As you could see just from CDC, the evidence for evidence-based guidelines is minimal. And so rather than trying to say we're going to come up with evidence-based guidelines, probably start with a position paper. And I've already put out the word to those of you in this specialty practice to let me know of your interest in serving on the work group that will be convening with STS. So there's still time to get on that. We have not taken the next step yet and to convene an interested. So that's good news. So there'll be something more coming out from STS. It'll take a while to go through, to get something on paper and then to go through the STS review and approval processes. But that'll be great for this specialty. Okay, so now we're really fortunate to have Steve Dickson indicate he's willing to share what they are doing in Orlando and what they've learned and how they're taking steps to potentially make some changes. And Steve, as you are interested in so doing, please feel free to invite Ivan to join in on that discussion with you.
Thanks, Debbie, and I will invite both Ivan and Eddie to join in because both participated in the discussions that we had here at our practice. Let me start by going over a little bit of the background on what led to our meeting and what we're going to be doing in the future. And that started from the survey that you all sent out back in, I think it was the November timeframe. And after we took it, the survey, I looked at the results and found out we had absolutely no protocol at all for prescribing. Some of the physicians would give a 30-day prescription for opioids. Some would give a 7-day, and some would even just have the hospitalist, but before the patients were discharged from their heart surgery, the hospitalist would prescribe and so forth. So we had prescriptions being issued by physicians with no protocol, as well as when I say physicians, by our surgeons as well as the hospitalist. So it was pretty much a disjointed protocol, if you will, in how those prescriptions were issued. And it really opened my eyes to the fact that we don't have any process in place, and we need to do that. And as an administrator here at our surgical practice, I've never given much consideration to that opioid prescribing patterns or the protocols, and basically it just wasn't on my radar until those two things occurred. One was the participation in the survey that you all sent out. And the second thing, I think it was serendipity more than anything else, is that about the time you all had sent out the survey, I I began hearing a couple of our surgeons, just through discussions and so forth, talk about the number of second and third time redo valve replacements that they were doing on non-compliant IV drug abusers. And just a couple of examples. One of the surgeons had told me that he was doing a second time tricuspid valve replacement on a patient who had the initial valve done about I'd say 6 to 8 months prior. So after the patient was discharged, they went back home and started doing the IV drug abuse again. They got endocarditis, the valve got infected, and we had to go in and do a second time redo. And just as recently as Monday, I was talking to another surgeon, and he was going in to do a third time valve redo on a patient. And the second redo that he did on that same patient was in December. So here we are 2 months later, going in and doing a third time redo on a non-compliant IV drug abuser. So, that really hit home with me as far as the need to have that front end look at the our prescription practices for the opioids. And it is interesting, in talking to some of our surgeons, they felt that, we're treating this more as cardiac surgeons from an acute perspective, and that really treating from an acute perspective, we don't see the patients on an ongoing basis. So they're going back to their primary care, they're going back to their cardiologist, et cetera, et cetera. So we really do, quote, lose sight of how those patients are being followed post-operatively after we're through treating them for the cardiac surgical procedure. So again, as a result of those two things, Eddie and Ivan, and you too, Debbie, we decided that maybe it wouldn't be a bad idea to have something done and started within our practice to involve your group as well as some of our staff to discuss the issues. And I think that going into that discussion, I had my own biases. I figured that the patients that would be calling our practice and requesting multiple refills for the opioids would be the drug addicts and the non-compliant patients. And so I was going into this meeting more with preconceived ideas that I had as an administrator on who would be asking for these drugs and how we would be doing it. So in the first week of February, Eddie and Ivan came down, and I pulled in our office nurses, and we sat down for, I guess, about 2 hours and discussed the IV prescribing practices of our surgeons and what our nurses were hearing and seeing from patients and so forth. And I'll be quite honest, it was quite an eye-opener for me. And Ivan, I think it was for you as well as Eddie.
Absolutely, yeah.
So it was interesting. And Ivan, I want to thank you for writing up the after action on this, because a lot of the discussion that I'm going to take from now on is the key takeaways and the opportunities and so forth that we had done and arrived at, if you will, in the meeting. So the first thing that we listened to the nurses talk about is as far as how to establish and what to look at when establishing some of the protocols were things like, let's look at the type of surgery that the patient is having. And I'll digress a little bit. I was kind of naive going into this meeting, thinking that we'll just come up with a standard protocol for issuing opioids, and it'll be maybe 3 to 5 days, and a minimum dosage, and that's it. And in talking to the nurses, it was interesting that their take on the issuance and how the opioids ought to be issued, again, for our patients, which are acute patients, if you will, post cardiac surgical, was to look at the type of surgery, and even more specifically, they saw the prescribing practices as starting from the type of entry into the surgery. And we said, well, let's look at developing a decision tree based on a sternotomy entry, based on a thoracotomy entry, and then based on a subcutaneous entry. So what the nurses, their experience in the practice and seeing the issuance and the pain, if you will, the pain thresholds for the patients, is that they were easily, the nurses actually jumped on this in a heartbeat, and they said, we see the sternotomy patients have more of a need for pain, maybe for a little bit longer. The thoracotomy patients are totally different, and the subcutaneous entry patients are totally different from that. So I thought that was something that was interesting, that we are now going to take a deeper dive into those approaches, and we're going to make a decision tree based on the incision type, the entry type into the surgical procedure. And other things that the nurses brought up were the patient's age, and it was interesting. The nurses said that for those patients that are 65, 70, 80, and so forth, they never ask for the opioids. They're fine with a aspirin or Tylenol or something to that effect. And they're saying that the younger patients are the ones that are asking for the opioids and such. So again, that was something that I never considered, is the patient's age. But again, they talked about the weight, the history of drug abuse, the history of drug utilization, the dosing options, the absorption rates of the medications into their system, and so forth. So it was a very, very good discussion that we had, and an eye opener for me. What I'm going to do is I'm going to stop. I've got several other bullets, but I wanted to stop and see, Eddie, if you and Ivan wanted to add to that, and you may have had other takeaways than I did.
Sure, Steve, thank you. This is Ivan. I'm just going to add a couple of points. As Steve mentioned, one of the biggest eye-openers for me was just the expectation that we would walk in there, and obviously we saw a need to standardize, felt that it could be done quickly, but learned very quickly that there was still a lot more to learn. And so, as we talked about earlier on the call, just getting the insights from different perspectives, understanding how the nurses saw this in terms of managing day-to-day pain as opposed to the opioid crisis, and really helped to expand the way I was able to think about the problem and how to approach it. And so the other thing that comes to mind as Steve tells the story is that, what's interesting to listen to and observe is that it sounds like Steve has been putting together the pieces of a puzzle from many different angles for a long time. And so, and again, it speaks to how, the first answer is not always the right answer. And there's always different parts and components of this issue that are involved. But if you work with different stakeholders at different levels, you're really able to pull the pieces together and develop a comprehensive strategy and approach. Steve, I will let you continue.
Yeah, very good. Thank you. Eddie, did you have anything to add?
No, go ahead, Steve.
Fantastic. Well, yeah, and Ivan, I certainly appreciate that. The other things that our nurses, other discussions and topics our nurses brought up was the fact that because the protocols don't currently exist, and within a small practice or practice, I guess, of any size, one of the things that they don't have access to and would like to have access to is the hospital protocols. In other words, most of the hospitals have their inpatient pharmacies work on protocols for diluted or for any of the other opioids. And it may not be a bad idea for us to have access to those protocols so that we can not only see what has been issued on the inpatient side to these patients, but also to see what the hospital's protocols are for issuing those. So I thought that was an interesting perspective from our nurses. And the final thing that we had discussed was the post-surgical prescriptions. In other words, what's the patient being provided for pain in the ICU? And then after they leave the ICU, what are they? How are they being followed in the PCU and step-down units and so forth? So again, our access to the discharge summaries of the patients is critical, which we do. We get those and we review those. But again, that was part of the overall discussion that we had with our nurses. So in summary, you know, the things that we had looked at with regards to how we're going to follow up and what we're going to do moving forward is to develop a process where we get the hospital involved in our development of an opioid prescription and prescribing protocol, and where we will voice our opinion, or not necessarily voice our opinion, but discuss with the hospital how we work together jointly. So what we've done is that we have set up a group with the hospital to discuss and to meet periodically on establishing these protocols. So our first meeting actually is going to take place Monday, this Monday, and we'll meet over at the hospital. And what we are going to include in that meeting is going to be a hospital pharmacist. We'll have a hospital pain management individual. We'll also have a care management, our care coordinator from the hospital. And the care coordinators at Florida Hospital, they work with the patient, work with the patient's family. They work on the discharge of the patient, and then they actually follow up with the patients after discharge, whether that's 1 day to all the way up to 20 days. So we're going to be looking at and discussing with each of those specialists, if you will, within the hospital, within this working group, how we can integrate not only their function, but also our private practice nurses, if you will, in establishing a protocol for these opioids. So we're excited about meeting. We're excited about the first meeting that we're going to have on Monday, and I will try to update this group periodically with how we're progressing and what we're doing with regards to the work group, if you will, for establishing these protocols. So that's pretty much what we're doing, and that's where we are.
Well done.
Sounds like there were several things that happened that opened your eyes, and I would imagine others as well, in your own staff, as maybe and with the hospital staff too.
Yes, absolutely. You know, I think that a lot of that, Debbie, has to do with us just not meeting frequently enough with the work group or whatever to discuss just protocols and processes, whether it's discharge summary, discharge planning, opioid prescriptions, and so forth, because we don't always know exactly what the hospital's working on. And as a matter of fact, during the discussion, we found that Florida Hospital is actually working on a care coordinating section, if you will, that is following the patients from discharge up to maybe 15 days post-discharge. So what they're going to start doing is anytime a patient is discharged from the hospital, post-operative, the cardiac surgical patients, when they're discharged from the hospital, if they have any issues, problems, questions, or whatever, they're going to call that section there at the hospital to get any issues that they have resolved. So again, those are things we didn't realize was going on, and so I think that's going to definitely help us. So just more from an operational perspective, I think it's important that that we here at Cardiovascular Surgeons continue to work with these multidisciplinary teams and groups, if you will, at Florida Hospital, so that we'll be more in tune and more aware of what programs and protocols they have in place that we can take advantage of. As an offshoot to this, and I know we've talked a little bit about this offline, and that is the quote offshoot is the tail end, if you will, of the over prescribing of opioids, and that's where we're running into as a cardiac surgical practice, the redos of the non-compliant patients. So we've also engaged Florida Hospital to run a lot of data and statistics on the volume of patients that we're seeing, and what we're going to do is to identify is it actually a problem, or is it just a perceived problem? And I think that once we get that data, what we'll do is we're going to establish a work group between our practice and Florida Hospital to consider how we approach treating those non-compliant continued IV drug abusers, whether it's, we enroll them. One of the discussions we're having now with the hospital is upon post-discharge, once they're discharged, enrolling them not only in a cardiac rehab program, but enrolling them with a hospital drug rehab program. So again, we're just scratching the surface with all of these issues, if you will, that are associated with the opioid epidemic that we have.
Well, here's a thought, Steve. The fellow from SAMHSA that I mentioned spoke last week, Dr. Tony Campbell. He was comical in the way he said this, but it had meaning. He said, a lot of people, when methadone clinics came into being, we're all for it, but, quote, not in my neighborhood. And similarly, as prescribers are dealing with patients who have opioid misuse disorder, they understand that buprenorphine can help, but not in my office, is sort of the corollary that he used. So I'd remind you that he also said there are grants available. And so maybe this is something you and Florida Hospital want to go to SAMHSA's website and learn more about. Medication-assisted treatment, which the third speaker in that session said really is a cornerstone for treatment. These might be the types of patients who would really benefit from that. And maybe you can get some grant money to study it.
Very good. Well, that's a good idea. But that's it. That's all I have. Any questions?
It's great work, and hopefully you'll, you will, as you said, you'll continue to provide us updates, and hope there's some takeaways for the rest of you. Steve, do you think that those recommendations from CDC will be valuable
Yes.
Even though they're written for chronic pain?
Yeah, I like the one of the I can't remember if it was 10 or 12, but one of the recommendations on acute patients was to give the lowest effective dose and immediate release, and
Right.
limit it to maybe 3 to 7 days. And that might be a starting place for us. And again, what we'll do is we'll evaluate that as it relates to the type of entry, sternotomy, thoracotomy, or subcutaneous. It may be that the subcutaneous entry only needs a 3-day supply, whereas the sternotomy entry needs a 5-day supply. 7 days. So we're going to start evaluating and looking at all of those issues.
Steve, will the nurse that we met with, I forget her name, will she be a part of that group, that work group?
Yeah, the nurse in our practice, Kim, and then the Dawn over at the hospital is also going to be part of that group. Yes.
And if I may, how did Kim respond to all of the activity that happened in the weeks since we met? What was her in the last few minutes that we have?
She really liked it, and I think she's going to definitely be engaged in the discussions that we have with the hospital. Unfortunately, the hospital sent out the agenda and the time for the meeting in the middle of one of our busiest clinics, so she's not going to make the first meeting.
Okay.
And I talked to the hospital about we got to do a better job planning these, but she'll be in all of the other meetings.
Excellent, excellent. Continue to fight for that. That's good.
Yep.
Okay. All right, so we're going to conclude now. I just want to remind everyone that if you have a story to tell, we'd love to hear it on one of our work group calls so that you can share it with others, as well as write it up. And I said that I sent the Word version of this story template with the email. I did not, but I will send it with the minutes. Next time, perhaps we can hear from someone else, as well as then focus a little bit more on assessing patients' risk of opioid misuse.
Debbie, can I jump in? Can I jump in
sure,
real
Eddie,
quick?
go ahead.
Can I just call on Susan? I know this is her first time on the Opioid Workgroup with us. Just wanted to see, Susan, if you heard anything interesting today that you would take back, and you know, anything you would change or do differently as a result of being on the call today.
Sure. Can you guys hear me?
Uh-huh.
So this is something we're actually just started talking about within our service over the past month. My role for the past 5 years, I'm the sole APC who takes care of every surgeon's postoperative patient. And I've been the sole person to prescribe narcotics. So I've kind of seen the trends in our patients over the years about who makes repeated requests, who doesn't, things like that. As well as, 5 years ago when I started, I was very liberal with the medications because that was the example my surgeons set for me. Now the surgeons have really ratcheted back, because of the problem, and I have followed suit. We're talking about just for really any of our patients, giving them a week's worth and telling them before discharge, we will give you enough for 1 week's worth of medication. And then we will expect you to then, transition to extra strength Tylenol. Now, we don't really have that really solidified how we're going to do it, but it's just what our goal is, to give them no more than 30 to 40. And we haven't really even come up with a number. Maybe it's 20 or 30 Norcos and, not even Percocet. And just trying to see if that's going to make sense and how much pushback we get from patients. We actually just had a meeting yesterday morning. We're looking for alternatives and adjuvant therapies, such as someone brought up that they had seen in the literature, maybe gabapentin, preoperative and postoperative can avoid narcotics or at least decrease the duration of the opiate. So we're getting ready to do a literature review to see if there's, anything supportive of that and discuss it a little bit further.
Great. So maybe we can hear from you in the future too.
Okay.
And hear how your work is going. Just at the back of the minutes, this was sort of late breaking information. So you'll see this. It was not in the agenda, but it will come around in the minutes. University of Virginia, an original VCSQI member, shared what they are doing for discharge instructions and says it has really cut down on phone calls to the clinic. So they were good with us sharing this. So you'll get all of these when I send out the minutes, if not later today, tomorrow. All right, thank you again, everyone. Thanks so much, Steve. Keep up the great work. We'll hear from you again, and Susan as well.
Yes.
This recording link will also be turned into a YouTube and made available to others. So have a good rest of the day, everyone, and be careful out there.
Very good. Thank you, Debbie. Thank you
You
all.
too.
Right.
Thank you. Bye-bye.
Thank you.
Bye-bye.
Steve.